Hello everyone, welcome back to the last session of pediatric dentistry question paper. So this session deals about the gingiva and periodontium of Pedodontics, that is kids gingiva and periodontium and its features. The first question is about features of normal gingiva in children and classify the diseases of gingiva and periodontal structures and explain in detail on acute hepatic gingiva stomatitis. So normal gingiva in children, we know it is pale pink, smooth, thick and round. Free gingiva is keratinized and endodontal clefts with retrocuspid papillae. Sulcus depth would be 2.1 to 2.3 millimeter. The red alveolar mucosa and wider periodontal ligament. Collagen bundles are more hydrated and less differentiated. Ground substance, there is low ratio of collagen to ground substance. And fibers, gingival fibers are immature trabeculae, the thick trabeculae with large marrow spaces. So we can classify gingivitis as acute, chronic and gingivitis associated with systemic diseases. In acute we have hepatic gingivitis and necrotizing ulcerative gingivitis. In chronic we have with local contributing factor and without local contributing factor. So what is acute hepatic gingival stomatitis? It affects both gingiva and other parts of oral mucous membrane. It's commonly seen in children less than 3 years of age, caused by the herpes simplex virus type 1. It follows a series of fever such as malaria, measles and chickenpox. The onset is preceded by a prodromal period with symptoms such as irritability, malaise, vomiting and fever, and presence of small vesicles which rupture to reveal small yellowish painful ulcers with erythematous margins. And it is also associated with drooling of saliva, inability to chew and swallow, and the child may become increasingly uncooperative during tooth brushing because of this gingival inflammation and other associated symptoms. But the condition is self-limiting, and the management is to encourage bed rest, provide plenty of fluid, and maintain a good oral hygiene through general debridement. Analgesics can be prescribed to relieve the pain, and application of mild topical anesthetic gel is recommended. So what is juvenile periodontitis, otherwise known as localized aggressive periodontitis or LAP? Very commonly asked question. It occurs in otherwise healthy children and adolescents without clinical evidence of any systemic disease. So it is characterized by rapid and severe loss of alveolar bone around more than one permanent tooth, especially the first molars and incisors. This also is a self-limiting disease, and retrospective data obtained from LAP patients suggests that the bone loss around the primary teeth can be an early finding of this particular disease. So next we have a long essay, that is children with special healthcare needs and their dental management with children with cerebral palsy, and not add a small note on oral preventive care of the cerebral palsy children. So Frank and Winter classified the special healthcare needs as blind or partially sighted, deaf or partially deaf, educationally subnormal, epileptic, maladjusted, physically handicapped, defective of speech and senile. New classifications: developmentally disabled or medically compromised. Agerholm classified an intrinsic handicap is one from which person cannot be separated, while an extrinsic handicap is one from which person can be removed, for example, social deprivation. So what are the oral preventive care for cerebral palsy? That is, patients should help brush their children's teeth after every meal, brush the tongue, since this will help prevent halitosis. Parents can help make children's teeth more decay resistant by using a children's toothpaste with the proper toothpaste and toothbrush. And up to age 3, parents should only use baby tooth cleanser to avoid fluorosis discoloration of the adult teeth. Children taking any oral medication should have their teeth cleaned after each dose of medication, because most of the medication is containing sucrose, which increases the risk of developing dental caries. And children should have their first oral health evaluation by age of 12 months and or within 6 months of the eruption of first tooth. Same question being asked: describe the management of child with mild mental retardation. First, we need to give the family a brief idea of the office before attempting treatment. Introduce the patient and family to the office staff. This will familiarize the patient with the personnel and reduce the patient's fear. Allow the patient to bring a favorite item, a stuffed animal, blanket, or toy to hold for the visit. Be repetitive, speak slowly and in simple terms. Alternative communication systems such as picture board or electronic device to assist with dental explanation and instruction should be there. Only give one instruction at a time. Reward the patient with compliments. Actively listen to the patient. They have trouble with communication, and the dentist should be very sensitive to gestures and verbal requests. And next, invite the parent to the operatory for assistance and to aid in communication with the patient. Keep appointment to a minimal time. Children with cerebral palsy may have a severe gag reflex that makes it difficult to take the dental radiographs. Slowly, we can start from the basic procedure to more difficult procedure, that is anesthesia and restorative dentistry, once the patient has become accustomed to the dental environment. And always schedule the patient early in the day while the dentist staff and the patient will not be fatigued. So the another classification we have NOVAX classification: physically handicapped, mentally handicapped, congenital, convulsive, communication, systemic, metabolic, osseous disorders, and malignant disorders. Again, the question of cerebral palsy was asked. So oral manifestation or common manifestation, we have, it's not oral manifestation, common manifestations of cerebral palsy: delayed milestones, muscle weakness, retention of primitive reflexes, apraxia, impaired cortical sensation, proprioception, or contractual deformities. Whereas oral manifestation, due to GERD, there is lots of dental erosion or loss of tooth structure, gingival overgrowth due to the seizure medication, and the tongue is hypertonic and cigar shaped. The tongue thrust during swallowing and speaking. Upper lip will be underdeveloped. It does not produce enough pressure on the front teeth to align them correctly. And the tongue in athiotic cerebral palsy, the tongue shows spontaneous wave-like motions. Abrupt and wide opening of the mouth can lead to jaw dislocation. Uncoordinated movement of tongue, jaw, and face muscles will be there. And orofacial findings in hypotonic cerebral palsy, the tongue is large, flat, and protruded. Facial movements are weak, and the upper lip is inactive. So consider treating a patient who uses a wheelchair in the same itself. That is, if a patient is to be transferred to dental chair, ask about the preference for the mode of transfer. If the patient has no preference, the two-person can lift the patient to the clinic. Make an effort to stabilize the patient's head through all phases of this dental treatment. Try to place and maintain the patient at the midline of the dental chair with arms and legs as close to the body as feasible, and patient's back slightly elevated to minimize the swallowing. On placing the patient in the dental chair, determine the patient's degree of comfort and assess the position of the extremities. Do not force the limbs into unnatural positions, and we can use immobilization for controlling movements of the extremities, but it should be very judiciously done. And for control of involuntary jaw movement, we can use mouth props and finger splint. And we should be careful that because these appliances may trigger strong gag reflexes and minimize the startle reflex reaction, such as abrupt movement, noises, and lights without forewarning the patient. And introduce the intraoral stimuli slowly to avoid eliciting a gag reflex. Okay, and because these cerebral palsy children have severe gag reflex, so we cannot take dental radiographs. So two modified radiographic techniques for use in children with cerebral palsy can be used, that is a 45-degree oblique head plate and the reverse bite wing. And always consider the use of rubber dam for restorative procedures, and work efficiently and minimize patient's time in the chair to decrease fatigue of the involved muscles. So, what are the clinical presentations? Special consideration: the management of children with Down syndrome, that is, they are with IQ between 30 to 50. So, where they have growth and skeletal abnormalities, prenatal, postnatal growth deficiency, and also a tendency towards premature birth. So, their osseous maturation is delayed, brachycephaly and flat occiput, large fontanelles, delayed closure, frontal and sphenoidal sinuses may be absent, maxillary sinuses may be hypoplastic, there will be ocular hypoteliorism, small nose with flattening of the nasal bridge, relative mandibular prognathism, upward slanting of palpebral fissure, then the ears, small, and the lips are broad, irregular, and fissured. The palate is narrower and shorter, but palatal height is not higher than that observed in the general population. Then there will be articulation defects. The voice is often hoarse, low pitched. Periodontal will be there in 90% of the cases, but because of the severe saliva uh, presence, the dental caries might be low. Eruption of both deciduous and permanent teeth will be delayed. Irregular sequence of eruption. Malalignment of teeth is very common. Crossbite, mandibular overjet, mesio-occlusion, anterior-open bite will be there. Management: we can have a pleasant, cheerful, affectionate, and cooperative dental procedures. We should work at a slower pace. We should emphasize on preventive dental care with frequent follow-up visits to monitor oral hygiene. Light sedation and immobilization may be indicative in those children who are moderately apprehensive, or we can try general anesthesia in severely resistant patients. Now, what are the medically compromised conditions in children? Management of children with factor A deficiency who requires extraction of a tooth. So, the common medical compromised conditions are diabetes mellitus, leukemia, hemophilia, thrombocytic purpura, any congenital cardiac defects, acquired immunodeficiency syndrome. So hemophilia A, we know it is a hereditary genetical disorders where our body's ability to impair or control the bleeding is it is having a problem. The coagulation is impaired. So there will be frequent series of bleeding. Hematosis common in these type of patients which is having symptoms associated such as pain, stiffness, and limited motion. Individuals may develop debilitating painful arthritis. Pseudo tumors might be there. So while giving local anesthesia, in the absence of factor replacement, periodontal ligament injections may be used. Infiltration anesthesia can generally be administered without a replacement therapy. A minimum of 40% factor correction is mandatory before a block anesthesia. Okay. For simple extraction, 30 to 40% factor is administered within 1 hour before dental treatment. Anti-fibrinolytic therapy should be there because these agents include epsilon amino caproic or tranexamic acid. In children, epsilon aminocaproic acid is given immediately before the dental treatment in an initial loading dose of 100 to 200 milligram by mouth. After that, 50 to 100 milligram per kg. is administered every 6 hours for 5 to 7 days. So after extraction is done, the direct topical application of hemostatic agents such as bovine thrombin can be used. Topical thrombin may then be sprinkled over the wound, or direct pressure with gauze should be applied to the area. Next, we have the developmental anomalies, that is anomalies of teeth. This we have already seen or already studied. Regarding the number, regarding the shape. Number, we have anodontia, hypodontia, micro, macro related to the size, position, structure related to the amelogenesis, dentinogenesis imperfecta, and regional or endodysplasia. Whereas the shape, we have gemination, fusion, concrescence, dense invaginators, uh, then taurodontism, hypercementosis, many other dilaceration. So all need to be explained if it is asked as a long essay. Various classification of cleft lip and palate. So this is sometimes will be asked in the oral medicine, oral maxillofacial surgery, OMFS. So we use classification group 1, 2, 3 and 4. Group 1, cleft of the soft palate. Group 2, cleft of the hard and soft palate to the incisive foramen. Group 3, complete unilateral cleft of the soft hard palate and lip, alveolar ridge on one side. Group 4, complete bilateral cleft of the soft hard palate and lip and alveolar ridge on both sides. Davis and Ritchie's classification group 1, 2 and 3, prealveolar cleft, postalveolar cleft and alveolar cleft. In prealveolar, lip cleft only with subdivision, unilateral medial and bilateral. In group 2, post-alveolar, degree of involvement of the soft and hard palate up to alveolar ridge and submucous clefts also included. Group 3, complete clefts of palate, alveolar ridge and subdivision of unilateral, medial and bilateral. Another classification, hair lip and cleft, isolated cleft of the palate, given by Fogg Anderson in 1942. So this is Canam's Trips Y classification and Millard's modification of Y classification. This it looks like a Y. So we have lip, alveolus, palate anterior to the incisive foramen. Again, lip, alveolus, palate anterior to incisive foramen, right and left. Then we have anterior hard palate, then posterior hard palate and soft palate. It looks like a Y. Then we have a modification, that is coming nose and nasal floor, then lip, then alveolus, hard palate and soft palate. So we have the short notes anodontia, we already seen, that is this no teeth present. We need to have a prosthetic rehabilitation. It is associated with ectodermal dysplasia. Enamel hyperplasia, we know it can be a generalized pattern, localized pattern and smooth pattern, and also a rough pattern. So obturator plate, that is a feeding plate used from birth to 3 months. It's fabricated after taking impression and is made of acrylic. It should be cleaned before and after each feed. Adjustment of the obturator are done once the primary teeth erupts into oral cavity. Ankyloglossia, we know it is known as tongue tie. It's a congenital oral anomaly characterized by abnormal short lingual frenum. So partial fusion, or in rare cases total fusion is there. It limits the range and motion of the tongue. It impairs the ability to fulfill its function. So Turner's hyperplasia is due to the trauma which is happening to the tooth, but because of the periapical inflammatory disease of the overlying deciduous tooth, this happens. We have, and the next question, child abuse and neglect. Describe the battered child syndrome and the role of dental surgeon. So child abuse, according to Gill 1968, it is defined as non-accidental physical injury minimal or fatal, inflicted upon children by a person caring for them. It is an overt act of commission of a caretaker, physical, emotional, or sexual. Neglected child, it is one who shows evidence of physical or mental health primarily due to failure on the part of the parent or caretaker to provide adequately for child's needs. The battered child syndrome, 1961, C. Henry coined the term. He developed the term seeing children coming into emergency room with unexplained accidents. He rediscovered the child abuse. It took the profession 90 years to really confront the child maltreatment. So he and his colleagues developed the criteria for abuse and provided legitimacy to address the issues of child abuse. So, what is the role of dentist in child abuse and neglect? So, he can identify and prevent the child abuse as follows: observe and examine any suspicious evidence that can be ascertained in a dental office, record according to the law. If any dental injuries, should be acquainted with management of injuries to both primary and permanent dentition, to establish and maintain a professional therapeutic relationship with the family, and transfer the child to physician or hospital for proper care. So advances in pediatric dentistry, that is nano dentistry, it is the latest introduction to dentistry. It will make possible the maintenance of comprehensive oral health by employing nanomaterials, biotechnology, which includes tissue engineering and ultimately dental nanorobotics. It includes nanodiagnosis, nanomaterials, and nanorobotics. So that was all about Pedodontic question. It was a 9 session series. So hope you had watched all the previous 8 sessions. If not, do watch to get a grasp of all the previously question papers of Kerala University of Health Sciences. So I'll be uploading all the sessions in one session, which will be very much helpful for the exam going students. So I'll come up with another topic in dentistry and more. Thank you. Have a good day.